farms in Europe as well as in the United States. And minks are animals that are very, very similar in type to other wild animals that we have, in various parts of North America. And we also know that the receptor that this virus uses to get into cells is very widely distributed. In fact, it's even in aquatic mammals, like whales and porpoises and so forth. So this is a promiscuous virus. It can go everywhere. And as I say, it's going to be with us for a long time to come.
So no substitute for prevention. And we'll get to vaccines in a little while, but I'm trying to generally take these in order so I don't miss any of them. So lockdowns, very controversial. Do you do it everywhere? Do you do it in some places? Do you not do it all? And how long do you do it for?
So when I was in China in January, the lockdown in Wuhan had been extraordinarily successful. And the reason it was successful is that you basically aborted transmission. You took a nidus of infection and you isolated it. If we could do isolation in this country for 2 weeks, and people did this religiously across the board, we would eradicate the spread of the virus. The Chinese went one step further. They went inside of families, identified people who were infected, and they further separated them. And that's how they got the outbreak in Wuhan under control. That is what we would do if we had a national government that had the ability to do this. But these kinds of decisions are made at local levels, at the state levels, and other even more discrete levels. And as a result, we've not had these kinds of lockdowns. But the lockdowns do work. And once you've done that in a very rigorous way, you can begin to reopen, but in a way that makes sense. So there's certain areas that are very, very risky. Any sort of an indoor event, particularly where alcohol is involved, or there's a lot of loud music or something like that, that causes people to talk more loudly, which gives rise to aerosols, is much more likely to spread this virus. So the most important thing we can do, in my view, would be the lockdowns, the personal protective equipment, and then as we reopen, venues like bars, indoor amphitheaters, things like this. These are the areas that have to be the last to open.
Now, it seems like what you just said, which is to isolate people who are infected, you would need to have a test that you could turn around the result of very soon, right? And yet that doesn't seem to be happening.
So the whole issue of testing is very confusing to people who aren't in this field, because you'll hear experts raising a whole series of different sorts of suggestions with respect to tests. The ideal test does not yet exist. The ideal test would be something that is definitive, that is sensitive, that is accurate, and that can be done in a very rapid time frame. It doesn't cost a lot of money. That test does not exist. There are people who are arguing for relatively insensitive tests and saying that if you do enough of them, you'll abrogate the course of illness because you're going to be eliminating most people who are highly infectious. So even an insensitive test is going to detect them. I'm sensitive to this argument. I can see why it resonates with some people, but I still prefer very sensitive tests. And my view on this is that when people are on the way up in terms of becoming infectious, you can identify and isolate them. So we recently ran a large convention where we did 10,000 tests on 1,500 people over a period of 4 or 5 days. And we identified several people who had virus by RNA PCR. We had no spread whatsoever because we identified them and quickly isolated them. So there will be inexpensive, rapid turnaround tests. One company I'm working with very closely is making such a test. It's going to cost about $25, and it's going to be used for school districts in Los Angeles and in New York and several other locations. And I think at a price point of $25 with a turnaround time of less than 24 hours, this is going to be very, very attractive.
So I think you answered the next question about quarantines by talking about isolation. So let's move to gloves. I see a lot of people wearing gloves, and yet we have heard that they are not particularly useful for a number of reasons. What would be your opinion on that?
Well, so the thing about gloves is what they do, they work in a few ways. One is they make it less likely you're going to touch your face and inoculate yourself, because it feels strange to take a glove and touch your eye, nose, or your mouth. So it has value in that respect. In addition, it shields you from touching infectious material. Now, we know that the virus has the ability to remain viable on different surfaces for periods of time that range anywhere from minutes to days. So on plastic and metal surfaces, with the exception of copper, where it's very rapidly inactivated, the virus doesn't survive for more than a day or two. On porous surfaces like cloth or cardboard, it lasts only a matter of minutes. So you're not going to have a substantial drop in your risk as a result of wearing gloves. But if somebody wants to wear gloves, I don't see any reason to discourage it. I just don't think it's going to be a real game changer. And you can always just continue to wash your hands, right? And the best way to do that is with standard soap and water. And I know people will talk to you about singing, happy birthday twice and so forth. I didn't do anything like that. I just lather my hands up, rinse them, and use a paper towel. And then I'm done. It takes seconds.
I personally have heard that you want to sing Her Majesty by the Beatles at the end of Abbey Road. And in fact, it does last 20 seconds.
Well, that's fine. I don't have 20 seconds.
Thank you for that. And that actually taught me something, because I think we have a Quizzify question that's a little more pessimistic than that I will be changing after this meeting to be a little bit more nuanced. Next question is, there's a rumor going around. Somebody says, my 83-year-old mother insists that running an overhead fan breaks up the virus particles. I'll let you have that one.
Well, it depends on what you mean by breaks up the viral particles. So I don't think it breaks up the viral particles. Viral particles are extremely small, much too small to be cut by the fan blades. However, if it circulates the air, moves it rapidly, and brings in fresh air, that would have enormous advantages. So if she's putting this thing into an open window and she's blowing in fresh air, I think that's a very useful thing to do. But it's not going to decontaminate. It's not going to decontaminate the viral particles, if that's the question.
Well, this is more about an overhead fan that might be running in an enclosed room that's air conditioned or something.
That's not going to do much for you.
All right. Second wave.
I hate disagreeing with a woman with 83 years of experience, but I'm afraid I have to in this instance.
Well, as we used to say at Bain & Company, when it's one thing having 83 years of experience, but some people have 1 year of experience 83 times. So I would take your opinion over hers. Next question. What are your thoughts on a second wave, and will it be as bad as the first, and have we learned things to mitigate it?
The concept of the second wave is very attractive to some people. I don't really understand when we say the first wave is ended, because as far as I can tell, we're still in the throes of it. We have a pandemic. New York, we've largely eliminated the majority of the disease. We're only seeing 100 new infections or so a day. However, I suppose if a new virus were to come in, right, which was genetically distinct from the first one, that would constitute a second wave. Now, that next wave, that next virus, if it came from Singapore, where the virus apparently has less pathogenicity, cause only milder disease, then we would have a milder second wave. On the other hand, if we were talking about what happened with the virus that came into the East Coast from Europe versus the one that came to the West Coast from Asia, the one that came in through Europe appeared to be more pathogenic. At least it was more capable of spread. So until we see what that second wave would look like, and that would have to be a virus that was genetically distinct in some fashion and had different properties in terms of its ability to transmit between people or to cause more disease, I don't know if it's going to be worse or better. People think that if it comes in the fall, that we would have more disease simply because we would not be able to distinguish between people who have flu versus those who have COVID. And this is one of the reasons why it's extremely important this year in particular to get your flu vaccines. And if you're over the age of 60, it's a different vaccine. It's 4 doses essentially instead of 1. And I can tell you from personal experience that it's more painful and it'll take you out of commission for 24 hours.
4 doses within 24 hours? Or
It's one injection, but it's got 4 times the antigen load. And it doesn't, and it typically, well, it doesn't agree with me. I will tell you that. My arm, it gets very sore and I don't feel well for about 36 hours. So it's good time to get it now as opposed to waiting later because we may run out if you're in that golden age like you.
So, yeah, like you and me. Thank you for mentioning that I'm in that age too. So let me ask you a related question, skipping to the question about the, you had said that there could be 2 genetically different variations. Let's skip to the question about a vaccine. Could a vaccine address both of those, or what do you think of the vaccine timeline generally?
Well, so the vaccine is our best way out of this. There are only 2 ways out of this because, as I said earlier, we're never going to eradicate this virus from all the potential reservoirs in wildlife and domestic animals as well as people. And particularly given that there are a number of people who've already said they don't want to take this vaccine. So the whole anti-vaxxer movement has gotten new life with the idea, of a national vaccine campaign. The vaccines that are being prepared contain a large amount of viral protein. The kinds of modifications that we're talking about with mutations or the evolution of this virus are not going to eliminate the value of the vaccines that are now being designed and produced. So that's not a major concern. I think that a vaccine will have a dramatic impact on the course of this pandemic in the event that we take it. And that's the key. If people don't take it, the impact is going to be less pronounced. Even if there is a failure on the part of some people to take it, there will be nonetheless some protective benefit for the remainder of us because there will be fewer people to amplify that virus and carry it to individuals who might otherwise be infected.
Is the end of the year timeline that we hear being talked about realistic in your view?
Depends on how you define the end of the year. So Donald Trump is defining this as prior to the election. I don't think that is feasible. I do think it's feasible for us to have it, at the very end of the year or the first quarter of 2021. And the reason I say that is that we've truncated the normal period of validation and safety testing of the vaccines in a way that doesn't, preclude our doing an adequate job of testing safety and efficacy, but is nonetheless more rapid. Now, the challenges in validating and testing a vaccine are that you have to find a way to identify a population of people who are very high risk for becoming infected, because you're then going to vaccinate half of them or some fraction of them in any event. And then you're going to give the other group either another vaccine or a placebo, right? To see whether or not this group is protected, whereas the other one is not. Well, if the virus isn't circulating frequently enough, you're not going to be able to do that vaccine trial. So there's a group now, it's called One Day Earlier, that's trying to line up vaccine volunteers who would agree to be vaccinated with 1 of 4 vaccines and then receive a challenge with live virus to see whether or not they're protected. And there is some support for doing this. I'm not recommending it, but I'm saying that this would be a way to more rapidly demonstrate the efficacy of the vaccine. It wouldn't tell you about safety necessarily. Safety, we're going to find out by immunizing many, many people and following them over months to see whether or not they have short-term side effects or longer-term side effects.
So it sounds like this is a situation where sometimes when you meet somebody in uniform or who's been to Iraq or Afghanistan, you say thank you for your service. I think we would say the same thing to people who volunteered for this vaccine.
Yes, I think this would be I think this would be an enormous service. So I'm just keeping track of the questions. We're doing okay.
Yeah, we're doing okay, and there's
right.
a bunch more lined up, but we're right on schedule. And if we don't get to the ones lined up, well, they had their opportunity to get in early. So I'm going to skip just a couple here because I think you've addressed them a little bit. So my physician practice, and this is a question for me now, where I'm actually on the board. It's the largest practice in New England, so I have a little sway. They won't give me an antibody test because they say the antibody tests are not accurate enough. What are your thoughts on that?
Depends on what you want to use the antibody test to do. If you are an epidemiologist and you want to know whether or not the frequency of infection is changing in a population over some interval of time or differs geographically, they have a lot of value. If you're talking about an individual patient and that individual is going to make a decision about whether or not to engage in riskier behavior as a function of whether or not he or she has been previously exposed, that's a different matter entirely. The antibody tests are not particularly sensitive. There are people who have documented infections who do not have positive antibody tests, and they are lulled, therefore, into a sense of, well, not lulled into a sense of security, but exactly the opposite. They feel as though they didn't have the infection when in fact they did. Now, this is only one aspect of immunological memory. The other is with what we know as T cells. These are cells that are activated by exposure. They release various molecules that have an impact on infected cells. And until we have a very good way of inexpensively demonstrating both T and B cell immunity in an efficient way, I don't think we're going to be able to be very helpful to people in terms of making predictions about whether they are or are not immune to the virus. So the concept of the immunity passport is not something that we can really talk about at present.
Okay, well, that was the next question, which was, do antibodies equal immunity? And it sounds like kind of, but not really.
Well, if you have antibodies to the virus, chances are good, right, that even if you became infected again, that infection would be milder with respect to disease. And what's been reported at least one individual in Singapore in the past couple of days is that somebody was reinfected. The virus was sequenced. This is not a paper yet published, except on one of these preprint archives. But the evidence we've seen thus far indicates that this individual had less severe disease the second time around. Now, they may or may not have had antibodies that were detectable using standard assays at the time that, this individual might have been seen. But as a result of prior exposure, the ability to make antibodies was there. The ability to generate T cell responses was there. So before the virus could take over, the immune system came in and quashed disease.
So it's an N of 1, but it sounds like you'd be fairly optimistic that even if you got sick twice, even if you got infected twice, you may not be sick twice.
Yes, but you're right. It's speculation. But my speculation is that you would have less severe disease.
So it's interesting so far. You've provided some pessimistic viewpoints on things and some optimistic viewpoints on things, which is exactly what we're looking for here, because the answer is not one or the other. It's nuanced. Earlier you had talked about the aerosolization through those the gaiters that people wear, the bandanas that have the when they go running or something. So could you comment specifically on aerosolization?
So Al, I just want to jump over the comments for a moment because there's a couple of things here. Okay, let me address these very quickly. Any evidence wearing regular eyeglasses, along with a good mask works? There isn't anybody, to my knowledge, who's looked at whether or not standard eyeglasses make a difference. I would suspect that they do, but the advantage to this face shield is it keeps your entire face free. And it actually keeps your mask clean as well. And you can easily decontaminate it. Now, where do you get a shield? There are many places to get shields. If you can afford it, I would buy one of the shields that costs about $40. They're much better, they fit better, they're more comfortable, and I think they're very, very useful. Neck gaiters, agreed with Duke. Not a good look. Not going to do anything for you. Would either of you participate in a phase 3 clinical trial testing a vaccine? I know many people who would. It's good. They're already oversubscribed. Would genetic testing help predict who is impacted by COVID or not? I think we will find such people. We do know that people who have immunodeficiency disorders, and those by definition are going to be either acquired or genetic, are at higher risk. The American Red Cross will do antibody testing for free if you go and donate blood. Yes, but if they test you and you don't find antibodies, that doesn't mean that you haven't been infected. So yes, if it's positive, you'll know you've been infected. Do you have any thoughts on which vaccine technology will work the best? I think there are going to be some excellent candidates for vaccines. I just gave a lecture yesterday in which I talked about 179 different vaccines, all of which are being tested at present around the world. I like the DNA vaccines, the RNA vaccines. There's also an adenovirus vaccine that's getting a lot of airplay. But I think there are going to be at least 4 or 5 vaccines that will come to the fore in the US. Okay, I think we're up to date now in the chats.
Okay, on the chats, we got a ton of Q&A lined up. But first, I just want to come back to something you just said that might be shockingly easy to do, if only somewhat effective. But it sounds like if somebody has contact lenses and glasses, they should be wearing glasses.
Sure.
Yeah, well, that's easy. I mean,
I like the face shields. I don't have my face shield with me, unfortunately. I have this cheap face shield that I don't recommend. This is the cheapest one you can get. It's got a little bit of, but there are some really nice ones. You can find them on any of the internet vendors. They're typically used for people who work around welding equipment, stuff like that. And they look cool.
Well, based on what you've just said, we were thinking of restarting Ultimate Frisbee with just 2-on-2. I think we would require face shields for that. So that's a very
there you go. Absolutely.
Yeah, okay. Because so this is extremely useful. The next question is from an epidemiologic standpoint: is there any value when reopening a business or school in testing every returning individual for COVID-19 as a condition of entry?
We are doing this at the Mailman School of Public Health. Most schools I know are now doing this. What we're trying to do is to reduce risk as much as possible. In my laboratory, we test everybody twice a week. We've modeled this and looked at the impact of the testing and have decided that, at least here, you can easily justify that cost. Now, you have to find a place that's going to do this for you on a reasonable basis. You also have to use a test that is accurate. An inaccurate test gives you a false sense of security, and then people become more lax. It is not a substitute for wearing a mask, for physical distancing, all the other things. So we like to refer to this as a belt and suspenders approach. So what I recommend to people for whom I consult on these things are, the physical distancing, which everyone knows, the masks, which are bona fide masks, not gaiters, testing before you start, and at least once a week, better twice a week if you can do it. We also look at the heating and ventilation systems, and that gets to the issue of aerosols. What we try to do there is we use what are known as MER13 filters, which actually clean up the air and make it much easier to prevent these aerosols, which is floating viral particles on dust, from moving around and infecting people. We also tend to cover the toilets so that when you flush and you generate an aerosol, any virus that might have been present in feces doesn't also come up. So these are all the things that are sort of the mainstays of risk reduction in the workplace.
I don't hear you mentioning taking people's temperature when they come in, which is very controversial.
Well, I don't see any reason not to do it for some of the reason, but the majority of transmission with this virus is with people who are asymptomatic. So it's not going to do much for you. So if you have to pay to have somebody stand there with a thermometer, for example, and measure temperatures and so forth, and you can allocate that money instead for better masks or testing, I would go with the latter.
Okay. Now, there are a lot of old folks who are living rather isolated lives right now because their younger relatives don't want to infect them. So suppose you wanted to visit an elderly relative, you would stay outdoors, you distance. Is there a threshold of infection rate, like you might do that in, say, New England, but not in Florida? Or is it safe everywhere if you take precautions?
Well, nothing is 100%, right? So in a low infection rate, as you've said, certain places where we have very, very few infections in the general population, yes, this is something I feel comfortable doing. But I will also tell you that many people come to us, they get tested before they go away on vacation with an elderly individual. Even in those cases where they're living in a low-risk environment. Because there are high-risk, things that you can do, right, even in a low-risk environment. So let's say, for example, you work in a restaurant or a grocery store. Somebody can come through that store who's visiting from Brazil or some other such place who's infected, right? So even though you've done everything you can to try to protect yourself, you become infected and unwittingly pass that on. So I still think unless you've been recently tested before you go into some sort of isolation with this individual, you should maintain your distance and you should wear your mask, as should they.
Okay, so I'm going to skip the last question because I think we know your answer, which is that there's no, well, I'll ask you anyway, there's never been a trial of hydroxychloroquine along with zinc and whatever that last thing was. Zithromax. Putting them all together, is that going to be any different than hydroxychloroquine?
I don't think it's going to have any impact whatsoever. There actually have been trials of hydroxychloroquine with the Zithromax, but not with zinc. But although there's a hypothetical advantage to Zithromax based upon work that's been done in tissue culture, the blinded controlled studies that have been done in humans don't find any efficacy.
Okay, I'm sure I expected you to say that, but I wanted to make sure everybody would hear that. So one of the things that's frustrating in the U.S., and I'm now switching to the Q&A that have come in over the course of this, is that test results just seem to take much longer to turn around than they do in other countries. Why is that? And for contact tracing, that's huge, obviously. Why is that, and what can be done about it?
We need automated testing. I'm working with a company name I won't mention because I don't want to push anything in particular, but they have the ability to do 100,000 assays a day for $25 a test and turn it around in 12 hours. There are other such companies that are using automation to do this. And if the government were to make a decision that it wanted to do testing on this level, it could organize a project that would fund this kind of work. There's nothing magical to it. It's liquid handling robots and handling supply chains and doing it properly. We need leadership.
So essentially the technology is there, whether or not it's the company you're describing or...
Right.
Okay.
It's we could do testing on a much broader, much more refined scale than we do, if we decided that this was something on which we wanted to focus, but we haven't. Instead, we have a hodgepodge of multiple tests that are, that are vetted inadequately. It's sad.
So next question that came in is, I'm just looking at the time, so I think we're going to have time to get through most of these. How do you respond to these people who said that there's no evidence that severe lockdowns have ever worked, citing Sweden, which did not lock down and ends up having about the same rate of hospitalization and death as the US, according to this question?
Well, Sweden did not have the same rates if you compare it with homologous populations in Denmark and in Norway. They had more deaths, more disease, and more economic disruption. So Sweden is not an example of an ideal response to this pandemic. I'm sorry to disagree.
Well, that's why we have you here. So next question is, what are the prospects for the rapid point-of-care antigen tests like E25 Bio or the 3M rapid test? Are they going to be a thing?
Well, they are a thing. I'm not a fan of this approach because I think that we do have the ability to make more rapid, reliable tests. And, if you have a test that has 50% sensitivity, the argument is that if you roll the dice many, many times, you're going to capture these people. And you're also going to reduce the infectivity, the ability to transmit virus, because you're going to catch some people who you wouldn't otherwise catch. So I think that is an argument that I understand and appreciate. I think we can do better. I think we can have accurate tests. And I think that anyone who's interested in the epidemiologist would answer to you that if you had a choice between an accurate test and a less accurate test, you would prefer the more accurate test. So what we're trying to do here is make various compromises that we frankly shouldn't have to make. The government should invest at the federal level on making available tests for everyone. Just like, I feel this way about healthcare and other things in general, but we need to find some way to deliver accurate tests to people. It can be done.
Okay, so earlier I was trying to keep a flow going, but now I'm just taking the questions off the Q&A. If you're using the N95 mask, how many times can you use it, and can you wash it, and is it still effective, et cetera?
Well, you can't wash these, as many of them are made of. They have paper, for example, components. But what I do is the following. I get several of these masks, and I rotate them. And I simply write the day of the week, and I can wear them for a month. This is my Monday mask, and I got my Tuesday and Wednesday, and I just cycle through them. And at some point, as you air them out, it becomes clear that they're past their prime. There are other ways in which you can decontaminate masks, and you can find instructions for how to do that on the internet. I don't recommend putting them into a microwave because many of them have metal components that'll, it's not going to work well in a microwave. But there are people who've used pressure cookers and ultraviolet light or just hanging them up outside. You can use them more than once.
So the idea is that
I use mine 4 or 5 times, but again, I don't use them every day in that way.
The idea being that the pathogens will essentially dissipate on their own if you give them enough
Right.
time.
So typically on these kinds of surfaces, the virus is going to last for less than a day. It actually probably lasts for for minutes. But there's also bacterial contamination, which becomes an issue. But if you hang them outside in the sunlight where they get ultraviolet radiation, then it should take care of both of those issues.
So in South Africa, their flu rate of flu during their winter went way down because they were all wearing masks. Wouldn't that be something that we could be talking about here in the U.S. To argue for people wearing masks?
Yes, I agree.
And yet, so this is coming back on something originally you said. To clarify, are you suggesting that the U.S. should do a lockdown that includes removing family members from households when they test positive, and have that just be a 2-week thing, one and done?
We could actually, if we actually committed to doing this, we could flatten the curve to the point where it would truly be flat. But the thing is, you have to do that universally. You can't make it a sort of a mosaic, because if you do that, then it's coming up here and it's dropping here, and then people go from here to there. You have to do this in a uniform sort of a fashion. But as we've done this across New York State, for example, it had a dramatic impact. And then you slowly bring people back, but they have to wear masks and so forth. If you look at those people in the population who, for various reasons, chiefly economic, don't have the ability to do this, to isolate themselves in this way, these are the people who've been preferentially affected. This is where we have our highest morbidity and mortality. In those people who must work every day, have to use public transportation, don't have the ability to get the masks and other PPE that they need in order to be safe.
So Vermont is the only state that seems to have licked this. And any insights into why that is? I mean, there are other rural states that have not licked it.
Well, Vermont is a special state, isn't it? I mean, people, for the most part, people, they listen to their government and they seem to have fairly enlightened leadership. If you're talking about some of these states where they said, I'm not going to shut down the bars, I'm not going to shut down, large events where people want to mix it up like South Dakota, I mean, you're going to have problems.
So
the biggest risk is obviously the proximity, the juxtaposition of people close to one another in an area where they're speaking loudly, coughing, spraying one another with infectious material.
So it seems like at the protests and the counter protests, there had not been much infection, and yet at the motorcycle rally, which was also outdoors, and both of them were very loud, there was considerable infection, and no one was wearing masks at either. Very few people at protests and and also in Sturgis. Thoughts on what made that different?
Well, people do wear masks in these protests.
And that's basically different.
Most of the protests I've seen, people are wearing masks. Not everyone, I will grant you. And the police are wearing face shields, right? And, some of the protesters are wearing face shields. I think the protesters tend to be a slightly different demographic. I would say slightly, a different demographic than the people who go to the bike rally in Sturgis, South Dakota.
Next question. Somebody says that having O positive seems to reduce the risk of infection. Is that?
If there's an impact, it's very modest.
Okay. And next question is, I don't know how we missed this one the first time. What's the latest thinking on how long a person who has the antibodies might be protected from reinfection that could cause a serious disease?
That is an excellent question for which we do not yet know the answer. We're too early in the course of the outbreak. We know from primate experiments that at least 2 months seems to be adequate. And most people think that it's going to be somewhere less than a year, but we don't actually know.
Right, because we haven't had enough time yet. But theoretically, you could be protected and then not protected. It's not like getting.
Yes, except that there are exceptions, because now we have some instances where we've seen evidence of subsequent infection, as has been reported in Singapore.
So you had mentioned this much more potent flu shot for those of us over 60, guilty. Is there a name for that so you know what you're getting? And should you not get it if you're under 60, just get the regular one?
Well, if I think if you ask your physician about this, you'll find that over the age of 65, most insurance will cover it. Below the age of 65, in that zone, for example, 60 to 65, I think you have to pay for it. It's still going to be under $200, but it's going to be, in my view, it's worth it. Because you get more protection from it.
And what is the name of this? In case somebody wants to
I don't know, but if you talk to your physician, you'll have no difficulty finding it. And I think you can actually, I don't know that you're not going to find this in the local drugstore because they're doing lowest common denominator. So you may have to see a real healthcare provider per se to get
it. Your view as somebody who's in the demographic and was willing to put up with the discomfort is totally worth it.
Yes, just like I feel the same way about the new herpes zoster shot, which is also very uncomfortable. If you've ever had zoster, know people with zoster, this is a very effective immunization.
Now, this is the new one that should prevent shingles. Yes. A lot of people
is the trade name.
I'm sorry?
Shingrix is the name.
Shingrix, right. In short supply, I might add. But
it is in short supply. Yeah. It's also very painful.
Okay, well, I was going to get it once it gets in supply. Now I know it's not going to be a lot.
Well, I got it for your sister.
Oh.
So
that's how you know it's painful.
So I know it's painful because I heard about it. And by the way, they were my doses. So, there you go.
So we have 5 minutes and probably about 5 questions. So we're actually getting a couple more. So we should be in good shape. I'm going to skip to a very interesting one, which is, would either of us, meaning you and me, participate in one of these phase 3 clinical trials testing a vaccine? And I'll let you go first.
Well, because I've already had this virus, I would not be eligible. So I have to throw the question back to you.
Okay. Well, I have to be, one thing that I have a reputation for in the wellness industry is honesty. And I have to be honest, I would not do it. I have great respect for people who would. I'm just not one of them. So tough question, and I got to give an honest answer to it. Another question that should have gone up.
So I would pose it the other way to myself. If I had not already been infected, would I sign up for that? Yes, I would.
Well, guilty again, I guess, on my part, but I would.
I call that a split decision.
Okay, I'll take that. And here's another one that somehow we've missed that no one asked. Children going back to school in September, hybrid program versus totally online. Lots of trade-offs. What do you think?
I'm firmly behind doing the whole thing online until we have a vaccine.
Yes, I know a couple of teachers have actually quit rather than be exposed because they were over 60. And next question is, and those are.
There you go. Somebody's already answered your question. The name of the shot: Fluzone high dose of quadrivalent. That's it. Great.
Okay,
thanks, Michael.
Michael
Brothers.
Did everybody hear that? Michael Brothers. I should have known. Hey, Michael. So do you want to just repeat that? Because I'm looking at another screen. I'm not seeing that. So
there's Stephen Gauss, all panelists. Does he not love you as much as your sister? Yes.
No, I trust me. They've got a great marriage. All right. So next question is: do we have any? Well, of course we probably don't, but I should ask anyway. Do we have any idea how long this vaccine would remain effective?
No.
Yeah. Okay. Then we've got time for like 2 more here. Convalescent.
Binder says all panelists not lived in non-economists, so he's forgiven on the Sweden answer, but their economy did better. I'll have to read that and see what I think about that, but I know they had a lot more disease And the question is, what is the cost of disease?
And I got to tell you, I'm going to be agnostic on that one because I think I've read it both ways. So let's put that. We will send a follow-up question that, and we will check into that because I used to be.
And here's another one on obesity. Yes,
Yeah.
obesity is a definite risk factor, as are diabetes, emphysema, but obesity is one that we can do something about. Then Brian Shetter, wow, very political on the protests. I'm not sure what to say to that. I am very political on the protests, but I don't think that's what I meant. What I'm saying is there were more people wearing masks at the protests. If you look at those pictures as I've seen them, and I've actually not been in any of the protests, than I've seen in pictures of Sturgis, South Dakota. Sturgis, South Dakota also has, if you take a look at these people on those large bikes, many of them are obese as well. And the protesters, not so much. And that's not a political statement, I hope. But I appreciate that, Brian. I didn't mean to be political.
So I would add a couple of things here. One is it is a factual observation if you just take pictures of these things. And remember, you're talking to somebody here who's been on Fox multiple times and MSNBC and gets invited back on Fox. So there's no politics here. And let's end on a high one. How are you feeling? Have you fully recovered from COVID? You appear to be great.
No, I haven't. I have this lingering fatigue. This is a miserable virus. Don't get it.
All right. Well, I was hoping to end on a high note, but that's a very important caution for everybody. Sorry we couldn't get to every question, but Ian, thank you so much for being with us. This was amazing.
Sturgis was an older crew as well. See, this is great. Anyway, thanks. Always a pleasure to see you, Al.
And much appreciated, and my best to Catherine, who I, of course, haven't seen in a while either. And thank you, everybody, for being with us. And these were great questions. Really appreciate it. Anything we didn't get to, we'll get back. And we're also going to send a little quiz afterwards to see how much you retain. So you expect that in the next 24 hours. With that, Mark, I think we're signing off.